So I wanted to then finish up by talking a little bit about some family planning. This is a really important part of what we do in genetics, and one of the main reason that a lot of our families seek genetic testing. In order to counsel someone adequately about the recurrence risk of a genetic condition in their family, you have to first identify what the variant is. What is the actual cause of the genetic condition in that family unit? Once you're able to identify it, then there's the question of inheritance. And for dominant conditions, a parent that's affected has a 50% chance of passing it on to all of their offspring or each of their offspring. In a recessive condition, there's a 25% of passing it on if both parents are carriers. If only one parent is a carrier, then they're not likely to pass it. They're not expected to have an affected child, though half of their children will be carriers. And then in an X-linked condition, there's 50% of chance of passing it on with each pregnancy. But we see variability based on sex for who is more affected than others. So we typically see in X-linked conditions that males are more affected than females, but it remains that 50% chance of passing it on with each pregnancy. There are some other forms of inheritance that are not as common in the nephrology world, such as mitochondrial inheritance, but we didn't go through that today. It's not quite as applicable for this population. Genetic testing. So when a family wants to have answers prior to a pregnancy or during a pregnancy, there are some options there. Prior to conception, there are options to do in vitro fertilization with testing of the embryos. But this does require significant planning in advance and a high use of resources. It's also important to note that this is not something that can be done for every situation. In a child who has a de novo condition, so something that was new in them, and the parents want to know what the chances are of passing it on and want to have testing of embryos in the future, that is something that we're typically not able to do. So it can be very tricky, and it's important to counsel your families that they need to be speaking to a reproductive endocrinologist about their specific changes in order to move forward with something like IVF. There's also testing during a pregnancy, and this can include chorionic villus sampling, which is taking a small piece of the placenta, or amniocentesis, which is done by taking some of the amniotic fluid, and we can do genetic testing during the pregnancy. There's also the option of testing after birth. So in conclusion, I hope we've walked you through a little bit of how to read a genetic test report, the role of a genetic counselor, and really truly genetic counseling, and how you can integrate this into your practice. And then we've reviewed some really important genetic concepts in nephrology: mosaicism, some challenges with PKD1, genotype-phenotype correlation, and that's looking at the genetic change and seeing how it impacts the clinical aspects of somebody's care. Reduced penetrance and variable expressivity, so the differences within family members. We touched on digenic inheritance, and then gave you some tools to think about variants of uncertain significance and how to interpret those using functional studies such as metabolic labs, family studies, and ultimately collaboration with researchers. So I thank you for your attention, and I'll pass it back to Dr. Rastogi.